Thank you. Hi, I'm Alex Pavlovic. I'm a consultant in gender dysphoria. Thank you for inviting me to speak to you. I lead the Portable Gender Identity Clinic. Can I change the slides, or?
I think if you can tell me, I'll change them for
you. Okay, great, thank you. So if you can change now. How to access gender clinics. We have only a limited number of gender clinics in the UK, and they are national clinics. So GPs can refer to any adult services when the clients are approaching the age of 18. However, we see only patients after they turn 18. Usually, if the clients request their GPs to refer them to gender services before the age of 18, GPs would refer them to GIDS, so Gender Identity Disorder Dysphoria Service, which is sort of national service. You probably heard about some of them. The one is it's actually one national service in Tavistock with the Northern Branch in Leeds, but this service is now undergoing a review, and from the next April we'll know a little bit more when a CAS review is out. So we'll then know a little bit more about how the pathway for under 18 is going to work. So once the service users approaches the 18th birthday, the GIDS will make referral onto us, or as I said, the GPs can directly then refer to us, and we'll see the patient when we will accept the referral and see the patient after the age of 18. However, the waiting list is very long, so referring somebody at the age of 18 doesn't mean that they will be seen then. There is self-referral available at some clinics, but it's very important that we work very closely with the GPs, the primary care, as monitoring and prescribing happens in the primary care. Can you put now the next next slide, please? So these are the gender identity clinics in the UK. So Newcastle, Leeds, Sheffield, Nottingham, Northampton, and then Tavistock and Portman in London, and the Exeter. And the ones with the star also have the Gender Identity Development Service, so that's the under 18 service. And as I said, they are national, so any GP can refer patient to any of these clinics. So we, for example, would have a patient from Cornwall or from the north or from London, and vice versa. Can you please put now the second? Thank you. So there are also some community-based pilot clinics. There are only few in the UK. There is C Magic in Liverpool, covering Merseyside, Indigo in Manchester, and Transplus in Dean Street in London. And then there's also one in the east of England. So these work in partnership with the clinics and the local GPs, clinical psychologists, and also have a lot of support from the sexual health specialists and the service experts by experience, the peer support workers and experts by experience. Can you please put the next slide? So the team in Sheffield, in our clinic, and I think this is the composition of most of gender identity clinics in the UK. So we have quite a significant peer support work. So they are people who themselves transitioned and can provide a first hand advice and support to our clients. We have admin staff, the nurses, both the general nurses and the mental health nurses, operational manager, clinical psychologist, the specialist, in our clinic we have a specialist grade doctor, consultant psychiatrist, that's me. We have a consultant endocrinologist, half a session, half a day a week, and then we have 2 GPs with the extended role in gender identity and a physician associate. Can you please put the next one? So the process at Sheffield, once the patient is, so the timelines that I've given are the ideal times, but there is a caveat that currently, unfortunately, we are unable to meet these sort of time commitments, but we are working towards it. So at the point when the patient is assessed, we hope to assess them within sort of six months. There are 2 assessments, one by 2 different professionals. So one would be, for example, medic or psychologist, and the other one would be occupational therapist or physician associate or a nurse. If if both assessors agree, then the patient, then the diagnosis is made. Now we are currently using the ICD-11 diagnosis of gender incongruence, or DSM-5 diagnosis of gender dysphoria. So we don't use anymore the ICD-10 diagnosis of transsexualism, because now we see the gender on a spectrum, and for example, people with who identify as non-binary wouldn't fit into that category. So that has been abandoned. So once the diagnosis is made, we go into hormone planning, and we assess them for the suitability for hormones as a sort of medically irreversible treatment. Sometimes, if the assessment is a bit more complicated, they might have a longer assessment with a clinical psychologist, or sometimes the diagnosis is made, but the hormones can't be started because, for example, they want to preserve their fertility, or they might have general medical problems, or they can't start hormones for any reason, really. So then there is some delay until some more investigations are done, and then we work very closely with the GPs in terms of addressing general physical problems, or perhaps swapping some medication around to make the hormone treatment safer. However, a patient can start straight away voice and communication therapy. 6 months after they've started the treatment, they would have another medical review to see how they're progressing with their hormones, and then we would refer the trans females for facial hair removal, or trans men, if they wish so, we would refer them for top surgery, which is mastectomy, bilateral mastectomy, and chest wall reconstruction, masculinization. And then 6 months after that, we would refer them, if they wish so, and if they meet all the required criteria for the lower surgery, or sort of patients call it lower surgery, or we call it gender affirmatory surgery or gender confirmation surgery. So as I said, these are really ideal timelines. In practice, takes much longer because, for example, the assessment for the lower surgery requires 2 parts, and sometimes there is a significant waiting time between the first and the second opinion. Before we can, we need 2 positive opinions in order to refer them. In parallel to this, they might be offered psychological therapy. We also use a third-party organization called Gender Intelligence for Support, which is led by the experts by experience. And they stay involved with our peer support workers who also have lived experience, and they have a named professional who is usually a nurse who sees them every few months for review. Usually 6 months, but if necessary, it could be more frequent. Could you possibly now put the next slide? So I'm going to tell you a little bit of terminology. So cisgender is a person who has been who identifies with the same gender that they have been assigned at birth. So, for example, if somebody has been assigned female at birth and they identify as female in their life, later in their life, they are cisgender. And transgender if their gender identity differs. Oh, hello? Hello? Somebody's talking now.
I just sorted it. If you want to carry on, sorry about that.
Okay. Yeah. So the the transgender is if the so the transgender people would be the one who don't identify with the gender that have been assigned to which they have been assigned at birth. People who feel that gender is binary, they would identify as trans man or trans woman or cis man, cis woman. Sometimes people don't feel that they belong to any of the genders, and they would identify as a non-binary, and it's a spectrum, so they might feel more towards one end of the spectrum, so they would call themselves trans masculine or trans feminine rather than trans man and trans woman. So the terminology of assigned female at birth or assigned male at birth is sort of a newer terminology because we recognize that it's very difficult to talk about biological sex at birth due to intersex conditions, the sort of unusual karyotypes, androgen insensitivity syndrome. So frequently the genitals, well, I mean, not frequently, but there are cases where the genitals do not correspond to karyotype, or karyotype does not correspond to the hormones that are secreted, or the genitals are ambiguous. So this is why we talk about a gender or sex that has been assigned at birth by the parents or by the doctors. So transitioning is a process of sort of a physical process of changing gender. So it could be transition with hormones, with surgery. Some people talk about social transitioning, and that's the way they present, changing name, for example, or yeah, kind of how they introduce themselves to others at their work, or changing their documents, or how they ask their family to call them. So it'll be a social transition. Dysphoria is the subjective feeling of distress, of anxiety, low mood, in regards to the, for example, gender that they are perceived to be, or dysphoria towards bodily parts. So, for example, dysphoria toward genitals, or to secondary sexual characteristics. That naming is it's a sort of it could be done by a mistake, or it could be done maliciously, and that is using the name, the previous name before the person has changed their name by deed poll. And as I said, I mean, some people make a mistake and then they correct themselves, but sometimes people persistently use the sort of previous name to upset that person. Misgendering is referring them to be of a gender they don't want to be, as in sort of that they might have been assigned at birth, but they don't identify with. Pronouns, again, it's very important to ask people about their pronouns. She, her, he, him, or they, them, and then also about the titles. Could you possibly now change the slide? Okay, so the hormone therapy. So the masculinizing hormone, it's the testosterone. It can be done as a given as intramuscular injection, and there are several preparations. For example, a shorter acting is sustanon, given every 2 to 6 weeks, or Nebido, which is given around 12 weeks. We decided to, well, currently we're not really confident in recommending Nebido, because we noticed that there are issues with polycythemia, or and it's very difficult to actually get the steady levels. I mean, it is used and we do recommend, but currently we're sort of reconsidering the recommending it, because patients do struggle to achieve stable levels. I think it's just because there is a it's just to do with the pharmacokinetics of the drug. Transdermal, that's the daily application of the gel. There are several medication, Tostran, Testogel, Testim. So it's very important to monitor serum testosterone level when somebody is on testosterone treatment, also full blood count, because testosterone can lead to polycythemia and then subsequent thromboembolic events. Also, testosterone can lead to liver impairment and cardiovascular metabolic problems. So in our prescribing monitoring protocol, there is a whole list of different blood tests that need to be done. And then sometimes we also prescribe blockers, and that is to suppress female secondary sexual characteristics. We start, lots of our trans men start initially only on testosterone, and then if they're happy with the outcomes, they just continue. But if they would, if, for example, periods do not stop, then we would start them on a hormone blocker. Could you possibly go on to the next one? So these are the effects of masculinizing hormone therapy. I'm not going now to read all of them, but it's a useful sort of list of what to expect when. So these are some of these are desirable, some of them are not, but come with the use of testosterone. So sometimes, for example, patients complain to vaginal atrophy and painful sexual intercourse, or bleeding, and scalp hair loss, or oily skin and acne. But then obviously there are desirable effects like deepening of voice, clitoral enlargement, cessation of menses, body fat distribution, growth of muscles, and so on. Can you please go to the next slide? So the risks of testosterone, I already mentioned them. Apart from that, there are some inconclusive, which is risk of increased risk of uterine cancers, and this is why in our clinic we recommend that patients who are on testosterone for more than 5 years and have still have a uterus in situ, have the transvaginal, transabdominal ultrasound scan of uterus every 2 years. Yeah, again, there is a list here of all other side effects of testosterone. Can you please go to the next one? These are the blood tests that need to be monitored. As I said, full blood count, UNEs, LFTs, TFTs, prolactin, glucose, HbA1c, lipids, serum estradiol, serum testosterone, and then BMI and BP. I'm not going to go into details of the desired levels because they're all given in prescribing protocol in monitoring protocol, and they differ between different preparations. Can you please go to the next one? So the feminizing hormones are the estrogens, oral estradiol or transdermal, either gels or patches. We initially recommend transdermal because they are safer, and then our trans women frequently opt out to have blockers straight away rather than wait. Anti-androgens are sometimes used, but they have more side effects, so we don't really recommend them. That's kind of second or third line of treatment. Can you please go to the next one? So again, this is the effects and timescales of estrogen, the most desired ones are breast growth and change of body shape and so skin softening, but it can also cause decreased libido, which our patients don't like. Can you please go to the next one? So the risk is there is a risk of breast cancer. There is a risk of DVT, and the risks are greater with oral than with transdermal. There is a risk of cardiovascular and metabolic illnesses, also liver disturbances. Can you please go to the next one? So very similar monitoring requirements as with testosterone. Again, the difference, the blood tests are taken at a different time depending on the preparation. Desired levels are between 350 to 750 picomoles per liter. And initially we would recommend monitoring every 3 months for a year, then every 6 months for the next 2 years, and then every year for as long as they are on hormones. Can you please go to the next one? So we recommend, the hormone blocker that we recommend in our clinic is leuprorelin. It's usually first given in 2 test doses a month apart, and then a full dose of 11.25 milligrams subcut every 12 weeks. It can cause initial flare-up of hormones, but because of the sort of mechanism that it works on. It does cause QTC prolongation. So if the patient is on any other medication, has any other risk factors of QTC prolongation, we recommend ECG. And it can cause, it can lead to diabetes, cardiovascular disorders, edema, liver dysfunction. Can you please go to the next one? So surgical options so nationally commissioned by the NHS England, mastectomy with a chest wall reconstruction, phalloplasty, which is a complex surgery for trans men of 3 stages. Metoidoplasty is less complex and creates a micropenis. And then there is a vaginoplasty, which creates vagina with a cavity, and vulvoplasty, which is sort of a zero depth vagina. So it creates vulva, but no, there is no vaginal canal. And then standalone, which are not commissioned nationally, are hysterectomy and bilateral salpingo-oophorectomy and orchidectomy. Can you please go to the next one? So these are the screenings. We in our letters, when we send them to GPs, we include a link to the Department of Health screening program, which contains the schedule and instructions how to enlist and invite and who to invite. So, for example, both trans women and trans men should be invited to breast screening if they have breast tissue, cervical screening for trans men, abdominal aortic aneurysm for trans women. They wouldn't be, if they are just registered as female, they wouldn't be invited, but because of they've been assigned birth, male at birth, they should be. Bowel screening for both. Can you please go to the next one? So, as I said, we have a lot of work within our peer support network, and they can support patients while they're on waiting lists. Unfortunately, waiting lists are getting longer and longer. I've put contact details of our peer support workers, and yeah, they can support the patients online, face-to-face, email, phone. They also run groups and prepare people for assessment. Can you please go to the next one? Yeah, that's it. So I don't know whether you have any questions for me. This is the end of the presentation.
We've got 1 minute and quite a few questions. So